In the next topic, I will show you the result of our hospital. The outcomes were produced from the data between 2008 and 2021. We started the robotic thymectomy in 2008. Until the mid-2010, we could have only a limited number of cases because there was a big hurdle for high cost that the patient should pay for the surgical fee themselves. Recently, robotic thymectomy is rapidly increasing in our hospital because I think the patients come to understand the benefit of robotic surgery. Last year, we performed 140 cases of robotic thymectomy, which is more than half of our robotic case volume. If we look at the proportion of the different surgical techniques, we could find out that the number of open or vessel surgery was stationary for less than 10 years. However, the number of robotic surgery increased rapidly, and around 2/3 of the patients are receiving robothymectomy in our hospital. This graph shows the distribution of size of thymic tumors. As you can see, half of the patients had tumors with more than 5 cm. It means many of the robotic surgery was performed on patients with advanced tumors. You can also see there are many patients with more than 10 cm in size in the graph. This is the early outcome of robotic thymectomy in our hospital. The conversion to sternotomy was necessary for 4 patients, and the conversion rate was 0.7%. R1 resection occurred in 6 patients, and the R1 resection rate was 1.7%. The overall morbidity rate was 4.5%. However, most of them were minor morbidity. The major morbidity, more than clavien grade 3, occurred in 0.5% of the patients. The median length of hospital stay was 2 days. However, recently it dropped to 1.2 days, and recently 80% of patients are discharged the next day after operation. For long-term survival, our group reported the long-term survival of the early series of robotic thymectomy. The 5-year overall survival was 97% for thymoma and 95% for thymic carcinoma. We also evaluate the location and clinical course of the patients with recurrence. The location of recurrence was very heterogeneous. We didn't experience any local recurrence at the thymectomy site. And the prognosis after recurrence was not poor compared to other surgical modalities. I think robotic surgery does not increase local regional recurrence by poor handling of tumors or incomplete resection. I must conclude my presentation. Robotic thymectomy can be performed with better early outcomes than open or vessel thymectomy, according to the previous literature. Many different types of modifications can be performed by using robotic technology. Each modification has their own advantages and disadvantages. Early and long-term outcomes of robotic thymectomy were favorable. However, more studies on long-term survival are necessary for robotic thymectomy. Thank you for your attention.